Welcome back to Clinical Communication. My name is Ben. I'm a specialist physio and clinical communication skills facilitator here in the UK. And today I'm speaking with Brad Neal. Brad is a physiotherapy lecturer and researcher over at the University of Essex with a special interest in patellofemoral pain. Today we discuss communication around patellofemoral pain with patients, how we can bust certain myths, address various factors, how we should discuss more difficult conversations we may have with them, as well as how lessons from working in academia can help you with the patient in front of you. If you found this useful, please do share it with others and subscribe. Brad is available at Brad Neal on X or Twitter or on LinkedIn. He's also part of Team PFP on Instagram, and they have their own website, which I'll put in the description. Thank you for watching and listening. Enjoy it, and I'll speak to you next time.
If you wanted to teach a kid how to strike a cricket ball, that's what I tell my son anyway. Just watch Joe and you'll be all right.
Do we still have is it still the case? Do you have a strong batsmen who are weak bowlers, all rounders in the middle, and then strong bowlers who are weak batsmen at the end of your batting order? Is that still how it runs all these years later?
In Test cricket, definitely. I think, and I'm happy to be a cricket snob and say Test cricket comes before everything. But with white ball cricket and 50 over cricket, 20 over cricket, and now this abomination called the 100, which I'm not quite sure where you'd fit that in, but they're all having to do a little bit of everything. You're seeing, because you end up being a professional cricketer. You can do all things, right? You can bat, you can field, you can bowl. But when you become a professional, you normally only need to do one of them really well to be a professional. But particularly with white ball cricket, they're all doing a little bit more. You watch England play Test cricket, and you'll see Joe Root have a bowl. And he's actually got reasonable bowling figures, given that he's a number 3, number 4 batsman.
Unless you're wicketkeeper, and then you're a nominee. Is it expected that the wickie's a semi-decent batsman?
Particularly, it's ever more. And again, I'd blame white ball cricket. You can be a fantastic set of gloves and not make the England team. The most technically gifted keeper England have got at the moment is probably Ben Foakes, who plays for Surrey. But he very rarely gets into the England team because they don't consider his bat to be strong enough, compared to some other players. Although Jamie Smith, who's just broken through, is a very good set of gloves and he's an excellent bat as well. So yeah, they are definitely expected to do both. It's rare to have just a specialist keeper now. You've got to knock the ball around too.
Were you ever tempted to work in cricket?
I wasn't, funnily enough. I don't really know why. I haven't really got a good answer for that. I wanted to work in swimming. That was my sport. And when I realised I wasn't quite going to make it in the pool myself, it was natural to start to do some work there. And I like my rugby, so I ended up doing a little bit in rugby. And it's hard to work in elite sport and not get roped into football. So I did some football work as well. But no, never cricket. Bizarrely, don't mix work and pleasure. Maybe
no. Is that where it loses its pizzazz, so to speak, or appeal? Do you think because you're behind the scenes?
I mean, I didn't enjoy working in elite sport that much. That was definitely what I thought I'd like to do, and like a lot of young undergraduates, what do you want to do? Well, I want to work in sport, and I did a reasonable amount of it, and actually just didn't enjoy it that much. I enjoyed getting paid to sit and watch sport, but then obviously stuff happens and you have to do things, and it's quite all consuming in terms of evenings, weekends, that sort of thing. And not saying I don't work of an evening now as an academic, because I do, but and certainly did in clinical practice as well. But you've got no control over it in elite sport. You have to be there when you have to be there. You work Boxing Day, you work New Year's Day, you might be in on Christmas Day. It just wasn't for me, which is I thought it would be, and found out it wasn't.
I think I said the same. I was similar thing. I did martial arts was the one I did it for, and I think it's great when you're starting out because you get to see a lot of fresh, acute stuff that you wouldn't see in, especially NHS or even like sometimes private. And I think it gives you a better idea of how to handle a different group of people that aren't 60-year-old Ethel with a OA knee or something like that. It kind of
Mm.
broadens your horizon, so to speak. Um, but I think, yes, it takes a certain person who's really passionate about it to want to stay in it. I just, I think whether it was having starting a family or other reasons, I think obviously other things then appeal, don't they? Um,
Yeah, and that was definitely something for me. You know, I got married relatively young, I guess, for modern standards, and it's not conducive to family life for
no,
sure.
no. Um, Thank you for doing this, by the way.
That's
I
right.
said that earlier, and giving you the time. I thought I should ask. We're going to talk about the PFP and some academic stuff as well. Um, so you didn't not cricket, you did the sport, and I was listening. I don't know if you've been asked this in the past, but you may have been. Why PFP? Why patellofemoral pain? Did that you think, oh, this is where I want to spend my time and career?
Yeah, no, I have been asked that before. I get asked it a lot actually.
Yeah.
And again, the honest answer is I haven't got a particularly good one in the sense that I don't have it. I don't. It didn't kind of afflict someone close to me. That sort of thing. It's I always had a bigger interest in the lower limb, and was and still am a bit of a closet biomechanist. I did a lot of biomechanics research throughout my PhD and still do a little bit, and find biomechanics fascinating. Although I'm at the point where I think it doesn't explain that much of why things start to hurt, continue to hurt, don't respond to good quality interventions. Um, Other than that, it was just circumstantial. So when I left the NHS to go and work for Pure Sports Medicine, I met Christian Barton, who had done a lot of work in the PFP space. I decided I wanted to do a PhD a couple of years after finishing my masters. I had a few years out of academia, just working clinically, and then about 3 or 4 years later, decided I was going to do a PhD. Um, Played around with a couple of different topics, had a reasonable interest in tendinopathy as well. And what sold it for me was I went to the international PFP meeting, which was in Vancouver back in 2013. That was the first one I went to the year before I started my PhD. And it was just such a great collegiate collaborative group who kind of on the whole get along, collaborate, work for better outcomes and better clinical things, compared to, not wishing to cast too many aspersions, but there's a lot of competition in the tendinopathy field because tendinopathy afflicts elite athletes. There's some money to be made if you do things well, even for a short period of time, and it never felt that collaborative. Same a little bit for the ACL world, where I also had a reasonable interest. So I tried a few things on, and PFP seemed to fit the best, basically.
I'm sure ACL's got a fair amount of competition.
Absolutely, because again, it afflicts the elite, and with the elite comes money.
Yeah.
And it's not always that. There's quite a lot of competition in OA as well, because OA is a huge public health problem, and as a result, there's serious money to be had for research grants and certain things. So I do a little bit. I've done a bit of ACL work. I do a little bit of OA work. The longer you become an academic, the more you kind of start to branch out and do some different things. But no, PFP just seemed to fit the best. That's about as sexy an answer as I've got for that
Fine,
question.
fine. And you and Simon have the Team PFP resource available for
Mm-hmm.
people, and which we will mention at the end as well. But if people want to know about the reasoning behind it and the assessment and treatment options for that, people can go there and look into it. We're just going to focus on some of the conversations that people have with PFP. And I'll start with a broad one, and it might get refined in a bit. In this, thanks to yourself, Simon, and many others, we know that the PFP is influenced by a variety of factors, not just one thing that causes it. It's many things involved. We've got a person in front of you who you've assessed and you've diagnosed them with this patellofemoral pain, and they say, "What's that?" How do we help someone understand the kind of multiple components to PFP?
I think I normally start that by trying to tell people what we can be confident that it isn't. So whilst we have a very poor understanding of why PFP starts, what the primary nociceptive source is, that those sorts of things, there is some stuff we can be fairly certain about in terms of the misnomer of you've got it because you're female, for example. Well, if we look at the epidemiology literature, it doesn't seem to be linked to sex. If we look at the prevalence literature, it does appear to be a bit more common in women, but that can be explained by a variety of things. So people often come in with a very fixed idea of I've got this because I'm female, or I was told this is because I've got flat feet, or because I've got a tight ITB. Whilst we can't say what did bring your symptoms on, we're pretty confident it's not that. So kind of working through helping people to reason or unpick what they've been taught in the past is often a good place to start, I think.
Well, so you've led me on very well, because if I give some examples, we'll say that person who's come in who you're seeing for their PFP, they've been referred by another professional, and the professional tells the patient they need to strengthen their VMO to get better. We know now from research by many people that it's not just down to the VMO, but how should we unpick that, first of all, and they've been told and they come in and say, I need to get my VMO stronger.
So I approach it by trying to see the positive in the message, in a sense, in that you're coming in effectively asking to load a flex knee. You're asking to put stress through your quadriceps. Good things generally happen when we do that if we get the dose right. So let's not worry about what part of your quad we're going to target. We're just going to try and load the whole thing, and we're going to do that in a way that you can tolerate with the equipment that you've got available within the boundaries of your severity, irritability, etc. And I think, in my experience at least, fairly quickly people turn around to that line of reasoning, because most of the time they don't really understand what VMO is, what it stands for, so I think you can massage that away quite quickly and get them onto your line of thinking.
And
I mean, massage metaphorically, not
yeah. I guess you've got to be careful, as you don't want to dismiss it, because exercise and strengthening is one of the pillars of treatment, isn't it? But at the same time, yes, you're right. We can't be specific and say you only want to target this. I think what I was listening to the other day, it's more knee and hip, right? Are we at a better point just to say globally legs stronger rather than one specific muscle, even just quads?
Yeah, and kind of one of the misnomers I think about the PFP literature is, and this comes up with with the various different courses that we deliver, be it formal, informal, undergrad, postgrad, etc. Is people kind of say, what about the hamstring, or what about the gastroc, what about the soleus, what about what lives beyond the hip and the knee? But the reality is there isn't much work. People just don't really look at that in PFP, myself and Simon and our direct colleagues included. So I do think the kind of broad approach is a good message, and we're going to load through the hip, and we're going to load through the knee, and particularly as we start to think about end stage rehab and returning people to whatever functional goals they have, then chances are we are going to be thinking about what goes on through the foot and ankle, and possibly through the pelvis and lumbar spine. So I think initially you kind of start narrow and then get broader, and that for me links into the diagnosis side of things as well, because whilst if you take common anterior knee presentations, PFP, patellar tendinopathy, iliotibial band syndrome, etc., I think end stage rehab probably doesn't look that different regardless of the diagnosis, but I think early phase probably does. And the example I often give is, if you misdiagnose someone with PFP as having patellar tendinopathy and then you give them a heavy slow resistance program, I'm not saying it won't get anyone better, but the average person with patellofemoral pain probably won't tolerate that level of load, whereas someone with patellar tendon will. Conversely, if you misdiagnose someone with patellar tendinopathy as having PFP and we take all the focus away from the knee and only focus at the hip, the average person's not going to get better. So I think early phase, that terminology and dosage is really important.
You said earlier that you tell them what it isn't. What is your is this for reassurance? Is that or to help them feel more informed?
I think it's both really. So again, people often come in with very fixed views on, my knee's noisy and I can hear clunking and clicking and grinding, and I'm worried that it's cartilage degradation, bone on bone, those sorts of things. Well, we haven't got a fantastic example for why certain knees are noisy, but we are pretty confident that it's got nothing to do with the state of your articular cartilage. So same thing when people come in clutching imaging. Imaging can be very useful in the right case, but for the average person with patellofemoral pain early on, it probably doesn't give us that much guidance, because there's more articular cartilage on the back of your patella than anywhere else in your body. So if you live 20 plus years on the planet, that articular cartilage is going to start to wear. That's what happens to articular cartilage, and the greater the density, the more it can start to degrade. And as long as that happens evenly, doesn't need to worry. No different to what we understand about imaging lumbar spines and cervical spines and shoulders. Wrinkles on the inside and some of these nice analogies that definitely applies to PFP. So chances are, for the average person, this isn't an articular cartilage problem. Your MRI might say that your articular cartilage has changed, but that's because you're in your 30s and you've done some weight-bearing activity. That's not a problem. So that side of it.
Does it ever, that cartilage you mentioned, does it ever tear like a meniscal tear, so to speak, in that sense? Or is it just a case of it all like not gradually change over time, but I'm thinking of the classic meniscal kind of bucket handle tear, that kind of thing. Does the patella cartilage ever do that, or is it always just thinning down over time?
Yeah, no, it can. You particularly in younger, healthier people who have got nice sort of high density articular cartilage, you can get osteochondral defects and chondral flaps and things like that. You can see full thickness articular cartilage defects that lead to subchondral bone edema and bone marrow edema and things like that, which is, where for the right person, imaging and possibly surgical intervention can be really useful. That one of the challenges of patellofemoral pain is it's this huge, great umbrella, and there's various different things that kind of live underneath it, almost sub-diagnoses that we categorize together. So yeah, you can see those types of presentations normally in younger people, and normally with an element of trauma or mechanism underlying.
Okay. What do you tell them it's not? So you said earlier on you tell them what it isn't. What is in your spiel, what do you tell them it isn't?
So often it's not Chromalaecia patellae, so chances are this isn't because you've got soft articular cartilage or because your articular cartilage is rougher than an anatomy textbook tells us it should be. Chances are it's not inflammatory. So as a result, the Voltarol gel you're using, the ibuprofen you're taking, unless someone describes a clear inflammatory pattern, worse in the morning, worse at night, morning stiffness, those sorts of things. So those interventions probably aren't going to help you a huge amount. Often it's not patellar tendinopathy, or doesn't appear to be your fat pad. Lots of people come in with that misdiagnosis. If all you've got is a hammer, everything looks like a nail. Often people come in saying, "Oh, I've been told it's my patellar tendon." Well, no, actually, I think you've got PFP, or vice versa. So often that misdiagnosis side as well. I think they're the big ones.
Someone comes in with that x-ray that says the chondromalacia patella. We know that, yes, it's not as relevant as we used to thought. What if they come in and say, I've got this on the x-ray report, and they look a bit worried? What do you say to them to help them feel not so worried and reassured?
So I often try and approach it by pointing out all of the things that look normal. So one of the things that imaging is really useful for is identifying structural dysplasia, so shallow trochlea and tibial tubercle distances and these sorts of things. So you can often reassure people that they have a relatively normal knee. Your patella is the right shape, your groove is nice and deep, your patella is in a good anatomical position relative to the groove underneath. You can talk about the train and the tracks and those sorts of things. So going down that line of reassurance, and then with the Chondromalacia patellae side, yes, your articular cartilage doesn't look how it would have 5 years ago, 10 years ago, 15 years ago, etc. But nor does mine. I'm unfortunately very much knocking on the door of 40 next year, to be precise. And, I've had imaging of both of my knees, and, they don't look textbook normal, but I also don't get any anterior knee pain symptoms. So, no different to I've had my lumbar spine scanned, and I know it looks like a dog's dinner, but I don't generally get anything other than the odd random episode of back pain that starts to occur when you knock on the door of 40. So reconceptualizing it for people and using some of these analogies, I find, can be really useful.
That's because we obviously do it a lot for spinal pain, have all these graphs and things about, things you can find on people your age who don't know about it, and they've got the various changes. I presume it's the same for the patellofemoral joint as well. That we can
Yeah,
find.
there's similar work out there. It doesn't see quite as much press as the spinal pain stuff. I guess when you bucket spinal pain up together, and lumbar spine, thoracic spine, cervical spine, there's definitely more spinal pain than there is patellofemoral pain. We always used to have a friendly argument when I was at Pure. So the Claire Small, the clinical director of Pure, who's recently been elected to CSP Council, she would always tell Simon and I that low back pain, which is very much her baby, low back pain is the most common thing we see at Pure. And then we'd pull 6 months worth of audit data off of our system and go, well, it looks like the anterior knee is the most common diagnostic code here, and So, but no, PFP doesn't quite have the same sort of media cell as back pain. So there's lots of similar work out there, but it just doesn't quite seem to translate into the infographics that everyone likes to band around in clinic for some reason. I should probably do something about that.
The another thing that people, and it still happens, that people come in and say when they've seen someone else for their the patellofemoral pain, is they say, I've been told that my kneecap doesn't track correctly. Should we still be saying this? Or is it redundant? Like, we don't say shoulder impingement much anymore. So is that redundant term now? Or B, if it isn't, is there a better way to say it?
I think it's still relevant. I approach it as there's a better way to say it. In the way I approach it with patients is, so I wouldn't use this term, but arthrokinematics definitely play a part in patellofemoral pain. And if you've got a shallow trochlea, a flat patella, a laterally displaced tibial tubercle, the way load is absorbed by that knee is going to be very different to the load that's absorbed through an arthrokinematic normal knee. I, for example, have very dysplastic patellae and have dislocated both patellae several times over the years, but know how to control it and don't get any symptoms, so wouldn't consider any sort of stabilization procedure. So the way I frame it for patients is the way your kneecap moves relative to the groove underneath is because of your skeleton, and I can't change your skeleton. An orthopedic surgeon can try and change your skeleton, but unless your kneecap is unstable, and if you've got PFP, by definition, you don't have an unstable kneecap, because patellofemoral pain and patellofemoral instability are two slightly different things. So we're going to consider it as part of your prognosis. And if you've got a dysplastic knee, your recovery is going to take longer, but we're not going to worry about trying to do anything about it, because I can't, and a surgeon isn't going to consider doing so either.
No. And I mean, surgically wise, all I remember, apart from the, as you say, the ones that repeatedly dislocate, is there really, with the exception of those significant tears in younger people you mentioned earlier, are there really any other major surgeries for this at all?
Not for patellofemoral pain, no. I mean, the old school lateral release, and again, I think that can be quite a nice example for patients as well. 20 years ago, we would have released the tissues on the outside of your knee in an attempt to improve your symptoms, and we've got reams of data now that tells us that procedure isn't particularly effective and can leave you with an unstable kneecap, which is not what we want. So as you say, that the younger patients with significant osteochondral defects, chondral flaps, those sorts of things can do quite well. Outside of that, unless you're unstable, good orthopedic surgeons won't go anywhere near, and we've all seen random cases. There's one really random case that sticks in my mind of a young athletic chap who had very, very treatment resistant patellofemoral pain. We threw everything at him that we thought is appropriate evidence-based care for this person, and didn't do particularly well. Eventually convinced a surgeon to scope his knee. What did the surgeon do whilst they were in there? Not very much was the report. A little bit of debridement, a little bit of washout, etc., and the post-op recovery was fantastic. So the mechanism of that, how much of it was biophysical versus how much of it was psychosocial, psychosomatic, it's difficult to say. But no, on the whole, I think it's very difficult to justify going into someone's knee if they have patellofemoral pain.
I think, would that help with the rehab buy-in if we can tell someone that beyond us there's probably not many more options, there isn't a surgery? Does that make it, would you say that makes a difference to their kind of, I want to say, buy-in or willingness to engage, or not?
Yeah, I think it can. In that, how do I describe PFP to patients? So the way I generally approach it is, you've got an irritated knee. Something is leading to an irritation within your system, and we're going to find a way of reducing and hopefully eventually removing that irritation. There isn't really anything surgically we can do to achieve that, so you're kind of stuck with me. There are a couple of injections we can try, but again, the evidence base behind them isn't particularly good, and we generally avoid corticosteroid now because it can be chondrotoxic, and unless you've got an inflammatory synovitic knee, which can do very well with corticosteroid, the average person with PFP doesn't have an inflammatory synovitic knee, so we don't want to go sticking steroid in there. The only other real injection option is hyaluronic acid, Ostanil, whatever your brand name. Again, the evidence is pretty poor. I've seen patients that respond really well to them, whether that's the thing that then makes them buy into the rehab more so than anything we can do to convince them, But no, I think it can. There's no, the ceiling of care for this is quite low. We're not really going to look to inject many people. We're not going to look to take a scalpel to many people. We've got to find a way to rehab this out.
Yeah. And let's say you've assessed this person, you've made the diagnosis, they've explained about it, you've answered their questions they've got, and you make what you feel is an appropriate treatment plan, and this person's leaving the room, and before they go, they say, will this get better? What should we say?
Again, I can tell you what you shouldn't say, which so many people still say, this is self-limiting and within 6 weeks you'll be fine. The data we have just doesn't back that up. This is a persistent recalcitrant condition with a very poor long-term prognosis. So tell people that they're going to get better. It's going to require significant buy-in on their side. It's going to require some trial and error from a rehab perspective. And this is going to take months and not weeks, and sometimes years and not months. I used to say to people with tendinopathy, this will get better over months and not weeks, and sometimes years and not months. And it's absolutely the case for patellofemoral pain now. The headline stat we put somewhere at the start of most grants that we write, over 50% of people are still symptomatic 6 to 8 years post-diagnosis. This is a recalcitrant and sometimes recurrent, goes away, comes back condition. So if you tell people it's self-limiting and within 6 weeks everything will be fine, you're setting them up to fail, basically.
Okay, grand. What's next out of interest for research in PFP? What do you see on the horizon for it?
What we need, what we desperately need, is good quality long-term trials. We've fairly recently published a fairly sizable meta-analysis looking at all the high quality randomized controlled trials that we have in the field. we've got 6 interventions that are well supported in the short term, so up to and including 12 weeks based on Cochrane guidance, and nothing beyond that. So if you want to give me some really good evidence-informed treatment options for people with PFP, I can only really be confident in up to and including 12 weeks. Beyond that, it's a bit of a minefield. We're plagued by short-term follow-up, really small sample sizes, poorly designed trials. So that's a big challenge, and we're going to struggle to understand the intervention aspect of the condition well unless we start to fund bigger and better trials. And I don't think PFP is unique in that. Across the board, there's never been more research out there, and most of it's rubbish. So it's why that criticality in thinking is so important. I can't remember the exact stat on year on year how many more additional research papers are published compared to the year before. We're seeing reams and reams of systematic reviews being published when the actual empirical literature hasn't changed for a long time. So all these reviews are going to conclude the same things. So that's definitely one thing. I think the other thing is the epidemiology side. So if we want to try and prevent the condition, then we need to understand its epidemiology. We need to understand why it starts, and that's always going to be multifactorial rather than unifactorial. So big prospective cohorts with multiple analyses trying to understand that. We've just done a little bit of work looking at that in runners, not PFP specific, just looking at running related injuries, so kind of bucketing everything together. And it would appear that of everything that we put into that mixing bowl, and we put quite a lot of variables in because it was a feasibility study designed to inform using GPS trackers for data collection rather than a biomechanics lab. The one variable that came out was acute load based on effort. So there's a bit of a developing thought process around people seem to break down not because they suddenly start doing a lot more, but because they start going too hard. So it's effort rather than volume, basically. Okay. And I think that would be the case for PFP as well. And then if you go right to the other end, so these are my kind of 3 things, right? I care about trials and good quality trials and understanding how to treat people. I care about epidemiology. The other thing I really care about is treatment mechanisms. So if we want to get to a point of being able to deliver precision medicine and being able to understand how to treat Ben Wybrow when he comes in with his patellofemoral pain, understanding how these interventions work and the mechanisms that underpin them will help me decide, well, you need treatment X, whereas Fred over there needs treatment Y.
Yeah. Okay.
And I've got a fantastic PhD student at the moment on a scholarship over from China, doing some really good work in that space. So we're starting to understand a little bit of the prognostic and mechanistic literature. And
you've been obviously doing this academic work for, well, how many years now?
10 years total. I've been a full-time academic now for approaching 4 years.
Okay. And this is at University of Essex?
Yeah, correct.
And which you've been doing lecturing as part of.
Mm-hmm.
And I do a dabble in, but not to the same extent that you do. The other thing we're going to talk about is you, from now doing this for 4 years as a lecturer, from what you've, whether it's a training with that or just experience of delivering teaching to students, what have you learned from that you would then think, I wish I knew that when I was a clinician, when I had Joe or Stacey in front of me, that could have helped me explain certain things better, or I do this now different compared to how I did it then?
Yeah, so that's a lovely question. I think ultimately students and patients aren't that different in the sense that we're trying to impart some understanding, and everyone learns differently, right? So with patients and with students, you've got to have a flexible, adaptive approach, and if the way we explain something doesn't land the first time, then you need to try and land the message in a different way. I think what we do with, certainly with students, that we don't do with patients is sort of try and understand how well they've digested that knowledge, and if they've been able to apply it, So with students, we subject them to some form of assessment, be it an exam, an essay, a viva, an OSCE, whatever it may be. We actively test whether they've digested and can now apply the information. With patients, we often bombard them with information, be it verbally or in the form of a pamphlet or an app or whatever, but don't then actually go on to test whether they've understood it, whether they've changed their behavior because of it. So that's the sort of, I see lots of things being described as education in the clinical literature, and I look at it and go, well, actually that's just information provision, because you're not testing whether that person has retained the knowledge, whether they can now apply it, change their behavior, etc., etc. So I think they're the two big ones, in terms of having that flexible approach, but seeking to understand if people have understood and have therefore changed what they're up to.
The way, I don't know the best way to do this, but is we assess students. Is there a way we should assess patients for their understanding?
I suppose informally, maybe we do, right? So I think, is it Kieran O'Sullivan who kind of first coined the term? Maybe even before him. We all stand on the shoulders of giants from before, but that whole teach back philosophy. In terms of can you explain what I've just told you? And how would you explain to your significant other, child, etc., etc. So I think that it does go on. We're about to test it, actually. So we were fortunate enough to get some postdoctoral funds from the CSP. All those years paying my CSP membership, I finally got it all back in the form of a 6-figure research grant. And we're essentially going to be looking at whether education while people wait for physio is effective at reducing their healthcare consumption, those sorts of things. So it's a feasibility trial, so relatively small in the grand scheme of things. Half of the people on the waiting list are going to be randomized to receive our online education. Half of them are going to be randomized to just stay on the waiting list. And one of the things that we'll be doing is, within our online education, at the end of each module, there's a quiz. It's only, it's multiple choice, it's sort of nice and straightforward, but we're going to be looking to see if people that score better, reflecting a greater retention of knowledge, have better outcomes. So we're gonna look at it and then follow up qualitatively. So we're going to invite a subset of these people back for some qualitative focus groups, and as part of that, we're going to try and seek to understand, did the information we provided that you retained, did that make you change your behavior? Has that given you self-management skills that made you get to the end of the waiting list period and go, actually, I don't think I need that appointment anymore. I'm all right. I can manage this thing. I'll come off the waiting list.
Yeah, because a lot of sites will have, like, as you say, generic information giving on their website, like about basic conditions, right? To try and, as you say, help them in advance or not need it. But how should that be laid out? Should there be an assessment? Should there be a certain way, rather than just long web page of information? Should it be laid out? I guess your study will find out if it's the best way to lay it out. So
yeah, I mean the education tool we're testing was built with patient input, so we had some good PPI underpinning that, and the information that's on it, the format that it's in, the way that it looks and feels and all that sort of stuff is informed by patient perspectives. I think one of the challenges is making sure people are getting the right information. So one of the things we're doing in the trial that would not necessarily work in practice, and this is a wrinkle we'll need to iron out when it comes to impact and implementation, is if we identify an eligible participant and they agree to be randomized, one of the things we're going to do is bring them in and make sure that, to the best of our ability, and diagnosing this thing isn't anywhere near as black and white as some people would like to think, but to the best of our ability, yes, you have PFP and therefore should receive this information, or no, actually, I think this is a fat pad problem, thanks for agreeing, but we can't include you. Whereas in practice, it will struggle to be as effective. Let's say we get down the line and it does reduce the number of people that go on to see a physio, and it does change their pain and improve their physical activity and all these good secondary outcomes. The barrier will be, how do we when people are referred and land on a waiting list, how do we screen whether they should receive the education or not once we're at the point of implementation? That will be a bit of a challenge.
Yeah.
We've got some ideas. I think you could have people go through a kind of simple click and shoot diagnostic, profile of, did your pain come on gradually? Yes, no. Well, if someone says no and their pain came on suddenly, they don't have PFP, so you can get them out fairly quickly. Does it hurt when you go up and down the stairs, squat, run, all these sorts of things? That's less clear cut because lots of knee conditions hurt when you do those things. But we've got some ideas.
Is at the moment, because I do a bit of teaching, and I realised from now having teaching to patients that it's not something that I wasn't trained in at all and undergraduate level. Is any form of teaching or presentation training part of not even physio, but healthcare training at the moment, as far as you're aware? And if not, do you think it should be?
I mean, it certainly is in terms of academia. I've been through my postgrad certificate in academic practice, which gets you the fellowship of the Higher Education Academy, and you can go on to do senior fellowship and principal fellowship and stuff if you want to. I found it really useful, and I do try and impart some of that knowledge as part of my teaching, because ultimately, if you end up doing the sort of traditional route of you graduate as a physio or whatever healthcare professional, you land in the NHS as a band 5, most of the time you're expected to do some teaching, right? You deliver in-service trainings and those sorts of things. And I often look at the amount of people that offer teaching, be it formally, informally, paid, unpaid, whatever, and I can't help but sit there and think, do you actually know how to teach? Again, I see some stuff where I look and go, well, I don't really think you're teaching. You're just standing in front of a room and spouting your opinion for 8 hours. And, to credit, sometimes people appear to be lapping it up. One of my frustrations with particularly the postgrad CPD market is lots of people seem to want to open their mouth and have a spoon put in. And that's not how I teach. That's not how I teach formally as part of being a university educator, because that would never fly. So when Simon and I do our informal postgrad teaching, that's how we teach. We're not just going to stand up and spout on for 8 hours about how wonderful we are and how this is how you should treat PFP, and here's all the cases we've got better over the years. We want you to think. We want you to go away having received some new information, and it probably isn't going to change your practice on Monday morning, because you need to think about it and you need to reflect on it. And but unfortunately the world moves at 1,000 miles an hour, and people want cookie cutter recipes and band-aids they can stick on stuff, and it's a challenge for sure.
When I did my training, they describe it as you're facilitating learning rather than delivering learning, so to speak. Try and get it out of the person as much as possible. Is that right? In
Yeah,
essence?
absolutely. I can't think which famous philosopher said it, but I can't teach you anything. All I can do is make you think. That's the way I approach teaching. And I couldn't tell you the last time I stood in a lecture theatre and gave a lecture. We just don't use large group teaching anymore. We
Oh,
do small
really?
group teaching, we do workshops, we do problem-based learning, we do situated learning. We do all these sorts of things. We don't use large group teaching anymore, because the underpinning pedagogy is just not there. And even if you do use large group teaching, what the pedagogic literature tells us now is that you should aim for small group teaching within a large group. So even within your big lecture theatre, and I've got a good collaborator in maths at Essex. She's a biostatistician, and she does all the fancy modelling analyses that we do as part of these epidemiology studies. And sometimes she stands and teaches a room of 500 students, which is completely alien to me, because I think the biggest audience I ever spoke in front of was at IFOMT back in 2016, and that's just a one-off conference presentation. We just don't teach like that at universities anymore.
No, interesting. And yet, as you say, someone walking into to do their in-service training, or will just maybe stand there and point at the PowerPoint
Yeah.
for 45 minutes. It's one of those things, especially whether it's in services, whether it's you're doing some form of group that involves education to patients, whatever it is. Um, I don't know how much people get now, but certainly I think it's something that is, if we're delivering or we're supposed to be educating or helping facilitate the understanding of our patients, we need to at least have some training in it.
Mm.
I don't know what that looks like for the future, how that would be.
Yeah.
Um,
We do a bit at Essex, so
good.
we have a module called promoting health and activity.
Okay.
Um, so that sort of leans on the NHS long-term plan and making every contact count, and some of these broader health principles. And within that, there is an element of sort of patient education, health literacy, health consumer education, those sorts of things. So we do have a little bit of it in our pre-reg programs, possibly not enough. And again, that speaks to what students want. It's not uncommon to get feedback from undergraduate students. I want more practical. You didn't teach me how to do this wonderful thing, this manipulation, etc., etc. Well, there's probably bigger fish we could be frying in this day and age, but it's getting people to understand what physio is, or what physio was and is now becoming. And there's still quite a lot of resistance to that, because if you ask the average person on the street in the UK what a physio does, and they'd probably say, oh, they run on with the magic sponge, or they give massages. And we do a bit more than that, but it's hard to change that societal construct of what physio is, isn't it?
Yeah, of course. So we've come to the part that we discussed was going to come earlier. So as I asked other people, I'm going to ask you, and you said you had a few examples of what are the hardest patient conversations you've had. You can say as many as you like.
As many as I like, and I knew it was coming, and it's a nice thing to reflect on, actually. I'd probably I thought of two primary examples that I often use as part of my teaching. So naturally, within physiotherapy-led assessment and treatment, when we think about musculoskeletal outpatients, when we're thinking about spinal pain, we obviously teach cauda equina compression syndrome, right? And why we pay so much attention to it. And I'm always drawn back to the one and only case of cauda equina compression I've ever seen. And lots of physios who have been working as long as I have probably never seen a case. I've seen one. I think they say the average GP sees one case in their entire career, don't they? I recall this case so vividly because this patient came in with what appeared to be isolated lumbar spine pain. You can call it non-specific low back pain, you can call it low back, you call it whatever you want, but she had no neural symptoms, no leg symptoms. So as I think best practice dictates, we started some physiotherapy based care centered primarily around behavior change and exercise and all these sorts of things. And after that period of 6-ish weeks when this person's not getting better, oh, okay, we're working in private practice. I'm not concerned, but let's send you off. Let's get you that MRI scan that you came in wanting in the first place, and see what we're missing. And lo and behold, we were missing a significant disc sequestration that was leading to compression of this patient's cauda equina. So, she was still asymptomatic at the time. I remember getting a call from the radiologist saying, we found this. What do we need to do about it? I then spoke to a couple of trusted spinal colleagues, surgical colleagues, and my neurosurgical colleague went, she's asymptomatic. I don't want to touch it. Don't worry about it. And I was like, well, that's very different to the way, certainly, we were taught about cauda equina as undergrad students. We're taught that it's, the biggest emergency you're ever going to see, and this person must go to hospital now. I then spoke to one of my orthopedic spinal colleagues who was like, oh no, it's got to come out. There's no way that can stay there. She needs to come to theatre. She needs to come now. So I had to bring this patient in. And these things always seem to happen right around Christmas. It was, I think it was like the 22nd of December or something. I had to bring this young girl in and explain, look, actually, we have found something on your scan. It can be a very severe condition that typically requires intervention, but you aren't symptomatic of it. So I've already got a couple of informal opinions for you. You know, one of my neurosurgical colleagues who, you know, operates on brains and spinal cords and things isn't worried and wouldn't do anything. I've got another colleague who says, no, actually you should have surgery pretty darn quickly. What do you want to do? You know, and so naturally I think the first question she asked me is, what would you do?
Yeah.
And, you know, I thought, well, I don't know. I think if it was me, I'd probably have surgery. You know, I don't know if I'm mentally strong enough to walk around knowing that there's a potential ticking time bomb in my lower lumbar spine that could leave me with significant life-altering symptoms. Whilst you don't have any of them at the moment, you know, there is the potential there. But it was just such an interesting conversation because this person's, you know, gone from no concern at all to possibly the most concern we're ever going to have as physiotherapists treating people with spinal pain, and they're then looking at you for advice as to what to do. And in the end, she decided to have prophylactic surgery, and everything went well. And to the best of my knowledge, you know, away she still goes. But that always sticks in my mind.
Would you have
And
said
then
anything
sorry.
Would you have said anything different?
I don't think I would actually. I mean, as we often do as clinicians, that one of the first things I did was go straight back to my initial set of medical notes, and, you know, did I screen her appropriately? And, not only am I confident that I did, I actually wrote it down, which is, you know, as you should do. And I think my notes are pretty good on the whole. But no, would I have done anything different? I don't think I would. You know, and I think it shows there's a lot of narratives around imaging, aren't there, and those sorts of things. And I never worry about imaging because I've spent, you know, the majority of my solely clinical career in private practice, and on the whole I've seen the positive side of imaging. You know, as long as you use it appropriately and as long as you work with the right people, it's used to rule stuff out rather than ruling stuff in, you know, which is why, you know, does it bother me that most of my physician colleagues image people with back pain the first time they see them? Well, it doesn't, because I know I'll trust them to say, well, look, we haven't found this, we haven't found this, we haven't found that. Let's not worry, off you go. As opposed to how it can be used, which is, well, look, we found age and activity related change at your L4 spinal disc. Better do something about that, you know. So that's not my experience of imaging. So one of my main reflections on it is it's why I don't get too het up about people being scanned, because I think it's a really nice way to safety net stuff. But no, I don't think I'd have done anything different. And I think she made the right decision still, on balance. I still think she made the right call.
Sorry, I interrupted your second one.
Yeah, no, and I mean, I'm sure I've got many other examples, but another one that sticks in my mind would, and I need to be careful how much information I give away, but the one and only time I've seen an elite athlete, because elite athletes typically don't get patellofemoral pain, right? So, you know, you go to any one of Pure's now 8 clinics, and there's a big board in every one of them that all the elite athletes have signed when they come in. You know, they come and see Håkan Alfredsson with their tendinopathy and things like that, you know, but they don't generally come and see me because, well, they definitely don't see me anymore because I don't see patients there anymore. But, you know, having spent 10 years there, you know, I could probably count on one hand the number of elite athletes I saw that got to sign the board, because they just don't generally get PFP. But I recall one that did, and just probably fairly typical case outside of the fact that they were an elite athlete in terms of, you know, gradual onset, grumbling along, having some rehab, not doing that well, have a jab, still not doing that well, have another jab, still not doing that well, have some surgery, still not doing that well, you know, and they came to see me for an opinion. And my overarching thought was that, you know, I think this person probably needs to retire, you know, with the sport that they do and the demands of their knee and what I'm seeing. I just don't think you're ever going to get back to doing what you want to do at that elite level. And surgical colleagues involved agreed, etc., etc. And I was really worried about having that conversation because no one wants to be told that, right? But actually this person took it really well, and I think actually they were looking for someone else to make the decision for them. So, you know, that was a challenging conversation, but actually had a very positive outcome, because I think that's what they were looking for. They just couldn't get to the point of making the decision themselves.
And did you have that thought of they might need to retire before they come in through the door? So you projecting this, or is this form coming as you were talking to them and
No,
going through the session?
as we went through things,
Okay.
working through reams of paperwork and imaging and subjective exam and objective exam, and we generally, when you see these people, you bring them in for quite a long time. You've got them for certainly longer than the average 40-minute NHS new appointment slot or whatever. We were probably there for a good couple of hours.
Oh wow.
So just as these things formulate.
Okay. It's one of those things because if you can see it's coming, sometimes in a way you build up this kind of anticipation about, oh no, I've got to talk to them about this, and this kind of dread or whatever feeling is coming on because this difficult conversation you know you're going to have. In a way, I guess if you see it forming as you're in the assessment, then it gives you less time to stress about it or think
Yeah,
about it.
and ultimately, one of my values within clinical practice and life, I hope, is that we just need to be honest with people, which is why I'm not worried when patients say, why did my knee start hurting? I'm quite happy to say, I haven't got a good answer for that. I can speculate, and you told me that you changed this, and there's a bit of evidence over there that sort of aligns with that. But ultimately, why did this start? I don't know. But let's not worry about that, because why it started probably isn't going to be the thing that leads me towards how best to manage you. So let's focus on what I do know, which is that. So
And I guess in a way that's also a great example of where breaking bad news can end happy or at least satisfied. They weren't shouting, they weren't angry, they weren't crying, etc. Sometimes it can end well. They just sometimes need to be told. Sometimes telling someone this is going to be long term, they can go, oh, okay. Or diagnosing that condition that other people haven't been willing to diagnose and just giving it a label sometimes and help someone move forward. Um,
yeah, and now all the qualitative work we've done speaks to that. I get quite frustrated when I hear people saying that diagnosis doesn't matter, because if you talk to patients, diagnosis is everything. And the analogy that I use when I teach that side of things is, I use the example of, on the very, very rare occasion, thankfully, when I go and see my GP, normally because it's I'm bunged up and I'm coughing or whatever, and ultimately what I want to know is this going to be self-limiting and go away on its own, or do I need antibiotics? And in order to because I can't manage that myself, I need you to prescribe them for me. So I need that diagnosis in order to know about care. And I think PFP is the same, and I think most musculoskeletal conditions are the same. People want to know, what is this, and then we give it the label, and hopefully give them good quality information, prognosis, etc. It gives them back that locus of control. If we kind of skirt around the edges and don't give a diagnosis, and but don't worry, this thing's self-limiting, and it will be better within 6 weeks regardless of what we do. Not only does the literature not support that, you're setting that person up for a fail. You're taking away their control. If you want someone to commit to a rehab program 3 times a week for the next 6 months, I think they need to understand why. And it's why I think we need to look at things with that level of honesty. And I think PFP is another really good example of this, where we look at podiatry and foot orthoses, right? The evidence around foot orthoses for PFP is really strong. It's just as strong as exercise. We don't have a great understanding of what makes someone more likely to respond to one or the other, but people on the whole respond really well to orthoses. The number needed to treat is 4. So in simple terms, if you hand these things out like Smarties, you give a pair of orthoses to 4 people with patellofemoral pain, one of them's going to get better. Dumb luck, toss of a coin chance, and that's as lower number needed to treat as you'll find. And they're also way easier to be adherent to, right? Do you want to go to the gym 3 times a week, or do you want to put some of these in your shoes? And I think there's positive messaging in all of that, and it's about landing the right intervention with the right person. But if you're not honest with them, and the reason I link it back to honesty is, I think lots of physios don't like that line of thinking and they think exercise is more important. Well, actually, the evidence doesn't support that, and you could use either. What one does the patient want? You know.
Yeah, and I guess then if you offer it to them and they pick the one that they want, then they're more
Yeah.
bought into it because it's their choice, right?
Yeah.
And they're more like, think,
Shared
yeah, it is.
decision making, right?
Exactly. And I think what you said with the label, like with the scans, you said, right? It's you can get a report. It's what comes with it, the explanation, the normalizing of it, like with the label or a diagnosis. It's not just saying you've got this. It's then you've got this, and this means da 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 da. Da, you know, and
Hmm.
all the reassurance. It's all the extra explanation or the information that comes with it that can then influence how they feel about it, I guess.
Yeah, and hopefully most of the time demedicalizing it. You know, chondromalacia patellae sounds exotic and nasty. Kneecap pain sounds mundane, and ultimately that's what people have come in and probably told you they have. You know, they'll say my pain is here. You know, but kneecap pain is just so much more straightforward and digestible, and we frame it as irritation and give people the right information in order to understand why we've chosen exercise or orthoses or both or taping. You know, like my analogy for taping is if and when I use it, which isn't that often, but it's like paracetamol for a headache. Your knee is that irritated that I need to calm it down. Let's have some paracetamol. Let's go to bed for a couple of hours and then see how you are when you wake up again. If you need to use that intervention, you know.
And again, thank you for sharing those examples because I think it's the difficult conversations that it's nice when you give someone you see someone and they're on board and everything goes to plan and out the door and it's great, but it's the when things don't go to plan, um, but knowing how to handle them that can make life easier, I think.
Mm. Oh, the more you do it, right? That's the case with everything. The more of them you do, the better you get at them.
Yeah. I'm gonna finish by giving you an opportunity, a completely separate question, but an opportunity for the people like me listening, because I know you're a fan of baseball.
I am correct, yeah.
So why should people like me, whether it's in Britain or elsewhere in the world, watch and or play baseball?
I'll give you two answers because I think they're slightly different. Why should you play? Like if you like a bat and ball sport, and if when you were younger or even as a grown adult, if you enjoy throwing, catching, it's like being a kid again. You know, the baseball for me is one of the few points in my week where I don't really think about anything else. I don't think about work. I don't worry about what my kids are up to or where my wife is, you know, that sort of thing. It's the one point in my week where I can turn off and just be a kid again. So that's why you should play. It's bloody good fun. Um, why should you watch? I guess if you don't enjoy bat and ball sports, then you probably shouldn't. Right? It is a little bit slower than football, cricket, etc. But if you do, then baseball is often described as a game of chess with a bat and ball involved,
Okay.
and if you understand the game, then once you take the time to understand the game, it's just fascinating. The strategy behind it in terms of the way different pitches move and how someone will throw one pitch to set up the next pitch, the technicalities involved of trying to make contact, and because I think lots of people watch baseball and think, well, they're just trying to swing as hard as they can and hit the ball. Sometimes they are, but most of the time they're not. They know that there's a runner at third base, so they're trying to hit the ball to the right side of the field to score that run. And trying to hit a round bat with a round ball is actually look at this. I've got a baseball bat and a baseball in my office. So trying to make contact with that on that is one, really difficult, but two, to be able to direct it to go in different directions. It's just the talent involved is just unbelievable. And if you get like a lot of American sports, they do things well, right? So if you get to go and watch a game in the US and sit there with your hot dog and your big pint, over a pint of beer and sit in the sun, and what more could you want?
Is it a bit simplistic to say it's American cricket?
No, no, it's so different to cricket.
Is it? Okay.
Yeah, it's so different to cricket. Um, it's different to cricket because it's time limited, right? So
Mm.
you've got 27 outs to try and win a game of baseball. Whereas in cricket, you can, in theory, you can bat for as long as you want. If you bat all 5 days of a test, you won't win it, but it will be a draw, right? Whereas
Mm.
you've got 27 outs to try and win a game of baseball. So it's very different to cricket. I when I played cricket, I think I was a reasonable bat, but couldn't bowl. Whereas now that I play baseball, I certainly don't pitch, which is the equivalent of bowling. But at times I feel like I couldn't hit water if I fell out of a boat. Trying to hit a baseball is one of the hardest things I've ever tried to do. Whereas the defensive side of the game, fielding, etc., is where my strength lies. So they're very different sports. They share some similarities, and with white ball cricket, T20, 50 over cricket, etc., you can see baseball things coming into cricket. One of the big differences is how you throw a ball.
Yeah.
So the way you're taught to throw a cricket ball is totally different to how you're taught to throw a baseball.
Yeah.
You pretty much always throw a baseball as hard as you can,
Yeah.
whereas you can do that because the person receiving it has got a glove on, whereas you
Mm.
can't do that in cricket and unless you're thrown to the wicket keeper. So the big difference is arm strength. If you watch a major league baseball player play catch and throw a long toss and warm up, the way they can throw a ball compared to a cricketer is totally different.
If you'd have been Brad, the American physical therapist, instead of British physio, would you have landed up in baseball?
Yeah, quite possibly. Whether I would or not is obviously a rhetorical question. I think the other thing that I find attractive about baseball is it's just a grind, right? Like so
Yeah.
they play 162 games in a
Oh,
season. So
wow.
they play 5, 6, 7 days in a row, and then they have a day off, and then they go again, and then
Mm.
they probably play 30 spring training games, and then if you make the postseason, you might play another 10, 15 games. So it's just a grind, and you just have to. I think it's a good metaphor for life. Whatever happens the day before, you have to get up and go again the next day most of the time. So it's a. I think baseball fans are a certain breed of people. They
Do
enjoy that routine. High volume games.
you have a team?
I do. Yeah, I'm a San Francisco Giants fan.
Oh, yeah. You're not the only San
Yeah.
Francisco Giants fan I know,
Uh,
ironically.
yeah.
Interesting.
I
Okay.
landed there because the first game I ever saw was in San Francisco, and
Ah.
made sense to then follow the team that you've just spent a load of money on in the in the dugout store. But yeah, it's over here. I'm my other thing is I'm the general manager of Essex Baseball Club. So
Oh.
we've got four teams under our umbrella in every level of British baseball.
Oh.
Our national league team, so our top team, won the league on Sunday. So we're off to Europe next year to represent GB
Oh.
in the Euros, and we've got playoff semi final this coming Sunday.
Mm. Very good. If people want to know more about their local baseball team, they just search into Google, I presume.
Yeah, just British baseball and wherever you're based, and see what you find. Cambridge have got a team.
Have I? Okay.
Yeah, they're not very good, I'm afraid, but
It doesn't surprise me. They don't seem to-
we beat
it's not a
them.
place
We
for good
beat them
sports
four
in
times.
general, unless
We beat
rowing.
them 4 times this year. But well, they can be good because there's an American air base in Cambridge. So
That's true.
occasionally they lean on the American air
Ah,
base and can be very good. Most of
okay.
the time they're not very good. They weren't very good this year, unfortunately.
Okay. Now, just so people know, you can find you personally on X or Twitter and LinkedIn. You and Simon on Instagram at Team PFP.
Yeah, well,
Uh,
that's only ever me. Simon's
only
never
ever you.
touched that account. So if you talk to someone in that account, it's always me.
It's always you. Fine. And you've got your info on the Uni of Essex website as well. Is there, if people want you and Simon for your courses and other stuff, apart from those places, anywhere else they should reach out or find you?
Probably just the website, so teampfp.com. We've got some stuff on there. There's a variety of different resources. We've also got some online learning stuff on clinical physio and Trust Me Ed and a few other places. And then anything we do hybrid or face to face will be on our website. Yeah.
You can just reach out on contacts. That's
Yeah,
easy.
absolutely. Don't be shy. I mean, I find Twitter ever more of a developing cesspit, so I don't use it that much. I'm generally more responsive on Instagram than Twitter these days. But
Well, thank you for doing this and sharing all your advice and support. I've put all the links and stuff in the description. Anything else you want to say or plug before we let people go?
yeah, no, I don't think so. Just thanks for the invite. It was an interesting chat. Very different to the
Yeah.
average physio podcast. It was very enjoyable.
Oh, good, good. Well, as I told you earlier, I aim to do things a bit differently. And I'll thank you and I'll thank everyone for listening or watching, and we'll see them next time.